Okay, so we've gotten through the scene size up portion of assessing GI and neurologic emergencies. So the primary assessment, your first priority is always going to be those life threats. That doesn't matter which patient you have. You want to assess the patient's level of consciousness, their ABCs, and rapidly observe the patient and the environment. Oftentimes, a patient that has abdominal pain will have their knees drawn up because that does help out with that pain a little bit. Form your general impression, ask the patient about their chief complaint, determine if their chief complaint aligns with a life-threatening problem. For airway and breathing, abdominal pain may cause the patient to breathe pretty shallow, so their respirations are going to be relatively inadequate. So you might have to put them on a little bit of oxygen just to help them out. For circulation, you're going to want to look at like pulse rate quality and skin condition to see if you have any indications for shock. Check their pulses in both arms. A difference in the pulse strength may indicate an aortic dissection because the aorta is much closer to the left arm than it is to the right. If shock is present, it can be from two things basically in this arena here. Hypovolemia or severe infection, so septic type shock. If it's present, your interventions are high flow O2, placing the patient supine, typically in a position of comfort, keeping the patient warm. You also, at this point, just because we check for major bleeding, even though you won't be able to see it, you should ask them about any vomiting blood or black tarry stools because that bleeding can be significant and you can't see it. Then you'll go with your transport decision. Remember, if there's any problem with A, B, or C, then we're going to transport emergently. Ensure that you try and drive as gently as possible because we don't want to jar them around too much. That's going to increase their pain. For your sample, kind of ask a couple of other symptoms when you go through the S portion. So ask about nausea and vomiting, any changes in bowel habits, how their urination is going, weight loss, any sort of episodes of gas, either belching or flatulence. Flatulence is just a fancy word for farting. Pain, other signs and symptoms, and then just double check to make sure that pain stays in their abdomen and that it doesn't radiate up into their chest. Sometimes when you have cardiac issues, that pain can radiate down into your abdomen. So we want to make sure that we have a better idea of where the pain is starting and definitely don't want to miss something. For your secondary assessment, how your patient positions themselves is going to give you some clues as to what's going on. A patient with appendicitis may draw up that right knee closer than the left. Patients with pancreatitis tend to curl up on one side, kind of in the fetal position. So make sure that you're taking note of how the patient is positioning themselves, or if they make any guarding type movements. A normal abdomen is soft, non-tender. Pain, tenderness are the most common symptoms of an acute abdominal problem. If it's localized pain, that tends to give you clues to a specific organ that could be the problem. So localized means that you can point to the pain with just a finger or two. Generalized pain is kind of more of an area. Muscles of the abdominal wall may become rigid involuntarily, trying to guard that area that's hurting particularly. To appropriately assess an abdomen, you should explain to the patient what you're doing, place them in a supine position, let them draw their legs up and flex at the knees because that will help. Expose and visually assess the abdomen. Ask the patient where the pain is most intense and start away from that point. You're going to palpate the abdomen very gently because you want to make sure that there's nothing else going on. You want to feel, is it soft? Does the pain change when I palpate? Note whether your pain is more localized or if it's widespread. Watch your patient for a response while you're palpating. A patient may say they're in a 10 out of 10 pain on this side, but when you touch it, they don't do anything. That's something you should document. If they say that they do have tenderness, you can check to see if it's primary tenderness. So when you're pushing, does it hurt, or does it hurt worse when you let go? And then determine if the patient can relax their abdomen. Oftentimes when we start pressing on their abdomen, they go ahead and tense up. So we want to just see if they can relax. Vital signs, typically the patient is going to have that pain, which could be impairing their ability to take a nice deep breath. It's not uncommon to find a high respiratory rate with a normal pulse and blood pressure. That typically just means that the pain is high enough that they can't get that nice deep breath, or that they are lacking a little bit of oxygen, but their body is compensating. If you have a high respiratory rate and a pulse rate, and then signs of shock, that may indicate septic or hypovolemic shock. If a patient has a dialysis shunt in their arm, try not to take the blood pressure in that arm because you might end up damaging that shunt. It basically feels like a thick, bouncy tube in their arm. They will know that it's there. I mean, this is not a surprise to them, and they should be well aware that you should not be taking a blood pressure on that side. So when you go to take a blood pressure with somebody that's even mildly confused, they may be able to tell you one side versus the other, because there are reasons that you shouldn't take a blood pressure on one side. Having a dialysis shunt is definitely one of them. For reassessment, you want to make sure that you reassess frequently. It's often pretty difficult to determine what's going on to cause the abdominal pain, so we just want to make sure that we're keeping a lookout. Especially, has the patient's level of consciousness changed? Have they become more anxious? Has their skin changed, either becoming more pale or more sweaty? Has the pain gotten better or worse? If there's bleeding, has the bleeding gotten more profuse, or has it decreased? Have you provided any treatments for your patient? And if you did, has it changed them for the better or made them worse? Has an already identified problem gotten better or worse? What are the nature of any newly identified problems? Some people just have chronic abdominal issues, so they can tell you if this is normal or if it's worse than normal. Transport the patient in a position of comfort, and then make sure that you consider ALS. So we truly in the field are not going to be able to treat the causes of an acute abdomen. The majority of it is going to be something that is going to require antibiotics or surgery, something along those lines. But we can provide comfort for the patient and treat them for shock if they are headed that way. Sometimes you just want to treat the patient for shock even if they're not showing signs yet, because the chances are that they could go that way. You want to make sure that you position a patient that has a risk of vomiting in a position to maintain a patent airway, and try and use like a biohazard bag, a vomit bag, etc., to contain the mess. They even have, for patients that are slightly altered, they have these, I guess for lack of a better word, big plastic bibs that you actually put around their neck, and then you can pinch it out so that it stays open, and then all they have to do is literally lean forward a little bit and they can throw up in this bag rather than all over themselves. You definitely want to wear gloves, but you may want to throw on some eye protection, a gown, and a mask if somebody's throwing up frequently. When the patient's been released to the hospital, make sure you clean, especially things like gastroenteritis. They are very contagious, and you don't want that. You don't want your other patients to get that. Um, Wash your hands thoroughly, even if you are wearing gloves, still wash your hands. And then sometimes when you're transporting patient, just some low flow O2 through a nasal cannula can reduce nausea and anxiety. We typically don't want to put a mask over their face if they really don't need it, because that could um, cause problems if they were to throw up with that on. So, dialysis emergencies, patients with end stage renal disease or chronic renal failure, dialysis is absolutely necessary. Dialysis itself filters the blood and cleans out all of the toxins and then returns the blood to the body. This helps eliminate waste and normalize blood chemistry, and then it also helps reduce excess fluid because your kidneys are responsible for that. So if they're not working, meh. If a patient misses dialysis, they can have problems such as weakness and pulmonary edema to start with, and then they're just going to progressively get worse. There are some services that transport patients to and from dialysis centers, or sometimes we're called to just do a quick transfer to take them to or from their dialysis. A dialysis machine functions much like a normal kidney does. Patients that undergo long-term hemodialysis, which is dialysis of the blood, have a shunt that connects a vein and an artery to allow blood to flow from the body to the dialysis machine and back. Peritoneal dialysis is another way to dialyze somebody. So you actually take a dialysis fluid and infuse it into the abdominal cavity and then pull it back out. The fluid stays in the cavity for an hour or two, and then they pull it back out. There is a high risk of peritonitis with peritoneal dialysis. That's typically only someone that's going to need dialysis very short term. They don't want to do that long term. Some adverse effects of dialysis: hypotension, so low blood pressure, muscle cramps because of electrolyte imbalances, nausea and vomiting, and then either a hemorrhage or an infection at the access site. If your call involves a patient that's on dialysis, you're still going to start with ABCs, just like anybody else. Provide high flow O2, manage any bleeding from the access site. If the patient has pulmonary edema, they're going to naturally want to be sitting up. So try and help them out. If they're in shock, find a happy medium. Transport them properly. Some dialysis patients also have urinary catheters, which are often a site of infection. So just be careful when you're transporting them so that you don't cause any more issues. You want to try and keep that catheter below the level of the bladder so that you're not taking fluid from that catheter bag and rinsing it back up into the bladder itself, because that just can cause the exchange of lots of bacteria. This is the last recording for chapter 18. We'll go on to 19.